Okay. Our next speaker is Edward Taylor, talking about integrating a model of tumor energy transport and consumption with routine clinical imaging to predict radiotherapy response.
I can hold it. Okay. Oh, great.
Big button in the middle moves forward, bottom one moves backwards.
Okay.
Down the top button for the laser.
Thank you very much. So in the span of 10 minutes, I'm going to introduce a model too that I think is of interest, or at least to myself and what I want to do. But because this is a very much a non-radiotherapy focused conference, I do want to take a few minutes to discuss some of the background of this. So just as a reminder, radiotherapy is given to about 50% of all cancer patients, so it is a major modality of treatment. And I think there's a lot of really interesting opportunities to incorporate mathematical modeling into the treatment of cancer patients. In radiotherapy, one of the great benefits of radiotherapy, and I'll allude to that in this brief 10-minute talk, is that patients get a lot of images, and they're not just pictures, they provide us with potentially functional information about the tumor, how many cells are there, how much blood is flowing through the tumor, what it's metabolizing. And so those are some of the things I'm going to touch on today. My overarching goal is to be able to predict radiation response. Of course, everyone wants to do this. On the left is kind of the standard sigmoidal tumor control probability versus normal tissue complication probability curve. And so we always aim to hit into this therapeutic window where we hope that most of the patients that undergo radiotherapy, we will be able to control their tumor, their cancer, without giving unnecessarily high toxicities. Of course, the reality of this is if you actually unpack one of these curves, it's immensely noisy. Different people respond differently. And so many people are trying to see if we can't deliver patient-specific radiotherapy. So if we know that your tumor is going to be very responsive to radiation, we can titrate, scale back down the dose. That's a big problem. I'm going to start with a baby problem, which is, can we predict hypoxia? So hypoxia is something that I've been thinking about for a long time. It's a state of low oxygen that often exists in solid tumor. And we know that it has a profoundly significant effect on radiosensitivity. So up to a factor 3 dose modifying effect. If you have a low oxygen environment, and that's just the physics of how radiation interacts with DNA to kill cancer cells. And so this has been one of the great problems in radiation therapy. And I would say after 30, 40 years, 50, 60 years of knowing about this problem, we don't have any really great ideas for how to solve the problem. Part of which is because we don't have a really good way of measuring it. So these are a couple of trials just showing you how impactful hypoxia is in head and neck radiotherapy. So we know it has a big impact on outcome. The problem is these are very difficult to measure. You see, these are relatively small patient numbers, 35 and 25. And that's because the way we tend to measure hypoxia, at least these days, is a very obscure class of PET tracers. So these are not the standard positron emission tomography tracers. All I will say about these is they are very difficult. I spent a long time thinking and working in this space. It's very difficult to do. It's not only is it very expensive, but it's difficult on the patients. These images take hours by the time the patient gets their injection to the time they're done. And you can't do that in a radiotherapy clinic in a scalable way. So questions, can we image them in another way? Can we somehow infer the state of hypoxia without using expensive positron emission tomography? And what's tantalizing for me is that hypoxia at heart is a very simple phenomena, okay? Boils down to, is the amount of oxygen that enters a tumor, is that enough, the rate at which oxygen enters in tumor, is that enough to satisfy the oxygen needs of the tumor? So if the flux of oxygen going into the tumor is less than the oxygen consumption rate, I'm going to get hypoxia. So that's pretty simple. You know, the devil's in the details, but I'm going to make a couple of assumptions. But the first and foremost is that oxygen is proportional, is provided by the blood vessels, so it's provided by the vasculature, so it's proportional to the oxygen flux into a tumor is really proportional to the surface area of the blood vessels that are entering the tumor The oxygen consumption rate, on the other hand, is proportional to the number of cancer cells. So two critical variables here are the cell density, which is rho, and the blood vessel density, which is F. And what's really exciting is that you can measure those in about 5 minutes using a type of magnetic resonance imaging scan called diffusion weighted MR imaging. So basically that's what I spend a substantial fraction of my time doing, is just acquiring these kind of diffusion weighted images for reams and reams of cancer patients. Okay, so this is the model. So if I want to, so on the previous slide, I gave you sort of the very high level version of the model. These are the specific assumptions. So the first assumption is that all the stuff that's coming into the tumor gets completely consumed. I call that the maximum frugality principle. If you think about normal tissue, we tend to, all normal tissue is optimized in terms of the vascular distribution to provide just enough resources to survive and to run when you're needed, and nothing more, because it costs an awful lot of energy to move blood through the body. The second one is that oxygen is the ATP production rate limiting nutrient. Oxygen is highly undissolvable in water. That has a huge impact on everything. Our vasculature would look very different if we relied entirely on glucose. Really, our vasculature is optimized to deliver oxygen. The other assumption is that cells move to regions of high energy availability. And the fourth is that lactic acid fermentation. So tumors, of course, have two primary metabolic pathways. They can undergo oxidative phosphorylation when there's lots of oxygen. Then they can also, and traditionally do, revert to a pathway where they're primarily relying on lactic acid fermentation. And I'm going to assume that that's upregulated to meet energy demands of hypoxic tumors. Critically, I'm not going to say anything quantitative about that because that's the subject of a lot of work. And I'm going to put all this together into a model, which I'm then going to validate on these diffusion weighted imaging that are acquired concurrently with hypoxia PET imaging. So this is a relatively small sample sizes because, again, this is very expensive. It's very difficult to accrue patients to these, but we have about 54 patients for whom we have these, 54 images for whom we have these data sets. So just very, very briefly, it's just all based on energy in, energy out, glucose in, glucose out. So we have to divide things by glucose and oxygen. I'm just going to show you to sort of give you a flavor of this, and I'll go right to the final result, which is a partial differential equation for, the interaction of, again, cell density and blood volume fraction. So something that would make this much more complicated is if I had an equation for the blood volume fraction, which a lot of people have done. I have the benefit that I don't have to do that because I can observe that in my images. I will just point out one thing very briefly is that this model, if you're in equilibrium, which I define to be this mu is a kind of a potential ATP influx term. If that is proportional to the vascular volume fraction, then you have sort of that in equilibrium and you recover exponential growth. So in this model, the tumor is striving to achieve equilibrium, which is actually exponential growth. It always fails to do that. So to validate the model, we have, two problems. One is that I don't have a longitudinal data set. So I have to, if I did, then I could just validate this model by using different images acquired at different times. So instead I argued, okay, if I look at this term, which is a gradient of, it's basically the vascular volume density over the cellular density. I look at the gradient of that, which I use to define my equilibrium, then I always find that in the center of these tumors, I'm in a sort of a quasi-equilibrium state. So I'm going to restrict my analysis to the center of the tumors and simply plot these density versus cellular density versus vascular density curves. And so in equilibrium, I expect the cell density to match the vascular density. So angiogenesis has kept pace with the tumor growth, and I don't have hypoxia. And this is sort of a very typical tumor for which I've done this analysis. And you see this very strong correlation between rho and F, indicating low hypoxia in my model. Conversely, here is a highly hypoxic tumor. So there's absolutely no correlations between density and cellular density and vascular density, which in this model is interpreted as upregulation of lactic acid fermentation. So we'd say, okay, well, the only way I can get sort of this dense cluster of cells here at this relatively low vascularization is if they're using lactic acid fermentation. And also this is sort of hypoxia. And we can actually co-localize these with PET images. It's not that clear, but this corresponds to a nicely PET-avid region, and it is aperfused. So, oh, one more thing. We are doing this so one of the things you do when you have imaging biomarkers, you try and see if you can make it work on other machines. So we have a number of MR scanners at Princess Margaret, where I work. And so we take this imaging biomarker and we sort of roll it across different machines at different time points through radiation treatment. And we can observe changes in hypoxia as we go through treatment. And also we can see concordance between different scanners, which is really exciting. So hypoxia is a major predictor of radiation response, but it's difficult to measure. There's been lots and lots and lots of work on simple image-derived surrogates of hypoxia. None of these have really gotten into routine clinical use. So my approach is, let's combine a model of energy, let's be a little smarter, combine a model of energy flow through a tumor with sort of standard of care images. And critically, this will allow us to scale this up. So we no longer have, the PET hypoxia imaging, that's sort of cut off now, but we can do this on, and we are doing it on pretty much, any cancer patient we want. So this is because these are really easy and fast measurements. So we're scaling this up, and then the next step will be to correlate with treatment response. Thank you.